Good morning, everyone. It's nice to see lots of familiar faces, and I'm really grateful to have the invitation to come speak here about this, which is the poison chalice of gastroenterology. It's not as sexy as bowel cancer. It's a lot trickier in my mind, dyspepsia. And like I said, I think this is one of the most challenging topics to discuss, other than fatty liver, which can put a whole room to sleep. Functional symptoms, similarly, but abdominal functions and dyspepsia, there's no New Zealand guidelines, there's very few international guidelines. It's incredibly difficult, but it's also a common presentation to primary practice. So I sort of wanted to take you through a framework that I use, and you might be thinking, gosh, why would you want to speak about this poison chalice? I want to talk to you a little bit about organic symptoms. Unfortunately, what I can't cover, but I covered at the Rotorua conference this year in an hour, was functional dyspeptic management, which I think probably is really important. But on deep reflection, when I've been trying to pare this topic down, I didn't think that I could do that justice. So maybe I could talk about functional management, which I think is incredibly important, another time, but I think maybe the safety of a framework of functional dyspepsia would be more important. So I'm a gastroenterologist, interventional endoscopist, and I try to chip out some of these rectal polyps that Adele was speaking about that perhaps don't need surgery, that are found early. And I've sort of got a large interest in research and teaching, and people said, well, this functional dyspepsia and dyspepsia thing, I'm doing a PhD on this now. In my spare time. And I went to Japan on my fellowship, where they have enormous rates of dyspepsia and abdominal discomfort and pain and malignancy there. They've got an Unko museum, which is a poo museum. And I think if you set up a poo museum on Simon Street, I don't think many folks would go, but they've got poo cakes and poo caricatures there, which we still have at our house. There's a 3-day wait list to go to the poo museum. And we had to go on a Tuesday morning to go there. This is a very big thing in the Asian communities, abdominal pain, dyspepsia. My wife is a GP. I've got these 3 children there that have sort of varying behavioural issues. But some of my interest and background in it was that she would ask me lots of questions about it, and there would be a lot of, in my mind, diagnostic uncertainty. And this is a very, very easy topic if you've got a gastroscopy, colonoscopy, and a CT scan. But it's very difficult if you're in primary care. And so that's what I want to sort of give you a framework, because this is sort of these are sort of the patients that come to see you and me. You ask them questions, they give you these answers, you don't know what's going on. You do it, if you've got time left in your 15 minutes, there's a bit of a systems inquiry you can rattle through. There's always lower GI symptoms as well. It's a bit of a nightmare, and you're thinking, oh my Lord, what's going on? And really, dyspepsia, the direct translation is difficult digestion, but it can mean all of those things there. And oftentimes in Asian populations and in Western populations, there's a completely different meaning. And in the Asian language, there's no direct translation for reflux or GORD. There's different words to use it, and so oftentimes we sort of grasp it in as dyspepsia. But in the West, oftentimes when folks say dyspepsia, they mean reflux, and in other times they can mean discomfort or bloating or pain or regurgitation. So it's really a whole big bunch of things, which is why it's tricky to sort of nut through in 10 minutes. But I wanted to give you my framework. And so I've just got 6 stars, and those are the things that I think are the big ticket items in primary practice that I think are important. Because 1 in 5 of these patients that see you very frequently have got an organic cause for their pain. And I guess the other way to think about it is 4 out of 5 don't have an organic cause and are in this functional dyspepsia or disorder of the gut-brain axis, which is what it's now called, disorder of the gut-brain axis, which makes it sound less like it's in your head and more like it's sort of a different thing. So, but of the folks, and I'm sort of veering into my other 1-hour talk that I couldn't help myself, but it's really important to note, of the 4 out of 5 that do have functional dyspepsia, a lot of these folks are very disabled. Off work, off school, sick notes, they're on medications that possibly they don't need. So I'm not going to cover all of that, but I'd love to come back or talk about that another time. But of the organic causes, 1 in 5, that's quite a lot for a very common presentation. So I think many of us know the alarm features, and I don't think that this is a surprise to many people. If you've got trouble swallowing and regurgitating solids out of your mouth, if it's really painful swallowing, if, the first degree relative's got cancer, if you've got lymphadenopathy, this is not a mystery. But I wanted to show you just a couple of ones that I think are important. If there's new onset dyspepsia in an older patient, that's very unusual. You really have to take that seriously than if it's a younger person, less than 55. And it really depends on ethnicity. Māori, Pacifica, Asian, older than 40 as opposed to 55 in other folks. And that's because, and I'll show you in the next coming slide, the risk factors here. So over than 40, you have to take that seriously. Recurrent presentations to your rooms, that's a red flag and I think deserves a referral to secondary care. And lastly, I always ask this pretty quickly off the bat, is this waking you at night? Are these symptoms bothering you? And that's a red flag. That's worthy of further thought. Very uncommon for functional symptoms. That includes, by the way, irritable bowel syndrome to have nocturnal symptoms. That includes nocturnal poos and nocturnal pain. And so that's another star there. That's 2 out of 6. So because, gastric cancer, we don't have the odds ratio, but 16 times higher rate of gastric cancer if you're Asian. And Māori Pacifica is probably 10 or more. I don't think there's any other ethnicity risk factor and disease that works together like that. Perhaps gout, Māori Pacifica, but Asian gastric cancer, enormous variance and enormous rates there. It's a very important if you work in Auckland where we have a very high demographic there. H. pylori, alcohol, smoking, salt, male, older, gender. The other really interesting thing that I didn't realise that when I went to on my fellowship was that, if you flush when you drink alcohol, which a large proportion of Asian patients do, that's the acetaldehyde thing, and that's a WHO class 1 carcinogen. So when you're flushing, you're bathing your entire upper GI, oropharynx, esophagus, stomach in this carcinogen. If you're homozygous for the gene, you've got no risk because when you drink alcohol, it's so painful, the flushing, that you don't drink alcohol. If you're heterozygous, which is the predominant number of Asian population, those are the folks that flush, but it's not so bad that you keep drinking anyway, and those are very high risk in population studies. So I always ask about flushing as well. I couldn't resist. I wanted to only include H. pylori. So this is a large part of my PhD, but I've just got 4 bits of advice I wanted to give on H. pylori. I took about 5 slides out, but really the only test that we should be doing currently in New Zealand for H. pylori is the stool test. Blood tests, very inaccurate. It's convenient because you can chip it onto other things, but it leads to a lot of issues with interpretation. So a stool test, yes, you do have to be off PPI for 2 weeks. Stool test is very accurate, almost as good as biopsy in terms of sensitivity, even better than specificity. The treatment, no one should be giving 7 days for H. pylori. The guidelines just got updated online for Auckland. They say 14 days, really 10 to 14 days. We don't know which either. I'll hopefully get that answer in 8 years. But really there's about an 80% success rate. Remember, H. pylori, if the patient is coming to you specifically with reflux only, H. pylori does not cause reflux. In fact, H. pylori, when you treat it, will worsen the patient's reflux because you're removing the acid suppression of the H. pylori. So of course, if there's dyspepsia and the multitude of symptoms, certainly something to consider. Think about what antibiotic you're going to use. Amoxicillin resistance in Auckland is very, very low. Please use amoxicillin if you can. And you must recheck. We're going to get that guideline updated. You have to recheck in 4 to 6 weeks after treatment. That guideline will be changed. So you should check because the resistance rates are so high now that that's the case. So remember that, please, folks. Remember, with these symptoms that we all know and remember, this is what we find. If you're having black poos and weight loss and nausea and vomiting, these are the findings that you'll get. If you've got dyspepsia, this is a time for us to intervene. Because look at this. This is early gastric cancer. This is what happens, and this is a really big difference in survival between these two. This is a patient, in both examples here, this patient already has gastric cancer. If you leave it for 3 years, this is what you'll get. This is the same patient. And there is a 10% miss rate at gastroscopy. If you are diagnosed in New Zealand with an upper GI malignancy, esophagus or your stomach, there's a 10% chance that you've had a normal gastroscopy in the last 3 years, because these things are very subtle to pick up. So really, modify the modifiable risk factors, treat H. pylori, and a one-off gastroscopy. Lester Levy won't be happy with me saying that, and that's sort of not always possible, is it? So as part of my PhD, we're sort of trying to come up with this poolbot. I've got 20 seconds to talk about this. This is where you can swallow this camera and drive it around with a PlayStation controller. This is me driving it in a fish tank in San Francisco. These are pictures of what it looks like. And so this is what it looks like. This is what will be happening in your GP rooms. You're going to bang them back in the weight room, tell them to swallow this. Someone else can drive this around. That picture on your right there is the first ever patient in the entire world ever to swallow this. You can see that patient had gastric polyps. Can you see that there? So that's probably deserving of a gastroscopy, and we can sort that out. This is the first time, and I'm doing the first and ever trial out at What a Matter Endoscopy out west in the coming days. We've got full ethics for this. So that sort of will hopefully. So the practical steps, you need to really figure out what the symptoms are and ask them really specifically, what they're having. Is it belching? Is it bloating? Is it satiety? What's the impact with meals? Is it before with meals or after meals? I think that's important, especially with regard to functional dyspepsia. Is this new or old? I think you guys asked that anyway, but that's important to remember to ask. And how long has it been going on for? Really, really important. So how long has it been going on for? And what has changed? Why has the patient come to see you if it's been going on for a year? That can sometimes be a clue. A lot of Patrick Gladding's medications, especially as colchicine, if you decide to take that up, will cause dyspepsia. Don't forget metformin, a massive one with change in bowel habit as well. I've just got 30 seconds here. So this is the important slide here that I think keeps me safe. 3 tubes of blood and 4 bottles of poo. Don't forget to do celiac serology. Really important. I've had someone who's recently, and I embarrassingly diagnosed it on gastroscopy, and when it came back as positive, I looked back and I hadn't even done that blood test. Very embarrassing. Do the basics well and do it right. Hep B, that's me just sneakily putting it in as a gastroenterologist, as a screening test. And then I think, especially with the coexisting abdominal lower GI symptoms, an H. pylori test, a calprotectin to look for inflammation, to make sure that they don't have an infection in the bowel. They don't necessarily have to have diarrhea for you to just do a one-off stool test. Like if you do it once, do it well, do it right at the start, then it keeps you and I and everyone safe in terms of ruling out the 1 in 5 folks with organic cause. Okay, and then a trial of PPI is absolutely appropriate. Very, very useful. I think, when you send it to a gastroenterologist, we always say double it and change it, but there's no good evidence that works. Okay, there's lots of other tests that we can do. We've got to get going here, but the last thing is just to say that, if you do those tests and it's okay, there's a 30 to 40% response rate just from the general general practitioner sort of giving them that reassurance and empathy. So this is lots of different folks, a lot of morbidity. These are the things that you can do in your practice on a day-to-day basis. Thanks for your time.